Osseointegration is a fundamental concept in dental implantology, describing the direct attachment of bone tissue to an inert implant material. This process is unique because it occurs without any intervening connective tissue, such as scar tissue or cartilage, between the implant and the bone. The result is a stable, rigid fixation of the implant within the bone, which is essential for its long-term function. Osseointegration is not defined by the absolute percentage of bone contact, but rather by the clinical stability and absence of symptoms during functional loading. This concept has revolutionized oral rehabilitation, allowing for predictable and durable implant-supported restorations. The primary definition of osseointegration is the apparent direct connection of osseous tissue to an inert alloplastic material. This means that the implant surface and the host bone tissue are joined without any fibrous connective tissue present. Alternative descriptions emphasize the formation of a direct interface between the implant and bone, again highlighting the absence of soft tissue. In oral implantology, this is verified microscopically, showing bone growing right up to the implant surface. The absence of scar tissue, cartilage, or ligament fibers between the bone and implant is a hallmark of successful osseointegration. Porous implants, also known as osseous integrated implants, are designed with pores that allow osteoblasts and supporting connective tissue to migrate into them. This enhances the integration process by providing more surface area for bone attachment and cellular activity. The pores facilitate the ingrowth of bone, leading to a more robust and stable connection. In dental implantology, porous implants are particularly valuable because they promote faster healing and stronger fixation, reducing the risk of implant failure. The essence of osseointegration lies in the stability of fixation rather than the absolute degree of bone contact. Clinically, it is defined by the asymptomatic, rigid fixation of the implant in bone during functional loading. This means that even if the bone-implant connection is not 100% complete, as long as the implant remains stable and symptom-free, osseointegration is considered successful. This practical approach allows clinicians to focus on functional outcomes rather than histological perfection. Brånemark's theory, developed in the 1950s, is foundational to modern implantology. It proposes that titanium oxide permanently fuses with bone, creating a direct connection without intervening connective tissue. For osseous integration to occur, the implant must not be loaded and should be left out of function during the healing period. This theory emphasizes the importance of a healing phase where bone is laid very close to the implant, ensuring a strong and stable interface. Weiss' theory of fibro-osseous integration offers a different perspective. It defends the presence of collagen fibers at the bone-implant interface, forming a fibro-osseous ligament. This structure is equivalent to the periodontal ligament in natural teeth and is interpreted as a peri-implantal ligament with osteogenic effects. Weiss advocates for early loading of implants, suggesting that the ligament can support functional forces and promote bone adaptation. One of the four crucial factors influencing osseointegration is the biocompatibility of the implant material. Commonly used materials include metallic, ceramic, and polymeric substances, with titanium being the most prevalent due to its excellent compatibility with bone tissue. Biocompatibility ensures that the implant does not provoke an adverse reaction, allowing for successful integration and long-term stability. The implant must be accurately adapted to the prepared site for optimal osseointegration. Precise placement ensures that the implant is surrounded by healthy bone, maximizing contact and minimizing gaps. This careful adaptation is critical for achieving initial stability and promoting the integration process. Any misalignment or poor adaptation can compromise the outcome and increase the risk of implant failure. Atraumatic surgical techniques are essential to minimize damage to the host bone during implant placement. Gentle handling of tissues and careful preparation of the implant site help preserve bone vitality and reduce inflammation. By avoiding excessive trauma, clinicians can create an environment conducive to healing and osseointegration, improving the chances of long-term success. An undisturbed healing phase is crucial for osseointegration. After implant placement, the site must be protected from excessive movement and functional loading. This allows the bone to grow and integrate with the implant surface, forming a stable connection. Disturbing the healing phase can lead to fibrous encapsulation instead of osseointegration, compromising implant stability. The absence of micromotion at the bone-implant interface is necessary for proper osseointegration. If micromotion exceeds a critical threshold, the body responds by forming a fibrous capsule around the implant instead of bone integration. This process leads to implant instability and potential failure. Therefore, maintaining a stable environment during healing is essential for successful osseointegration. Osseointegration is a dynamic process that unfolds over time. Evidence of integration appears after a few weeks, with a more robust connection developing over months or years. The interface becomes increasingly resistant to external shocks, but prolonged adverse stimuli or overload can damage it, resulting in implant failure. Understanding the timeline helps clinicians manage patient expectations and optimize care. The initial phase of osseointegration involves the formation of woven bone in the gap between the implant and bone. Woven bone grows rapidly, up to 100 micrometers per day in all directions. It is characterized by a random orientation of collagen fibrils and high cellularity, but has low biomechanical capacity. During this phase, occlusal load must be strictly controlled to prevent damage and ensure proper maturation. After 1 to 2 months, woven bone is progressively replaced by lamellar bone under load stimulation. Lamellar bone is more organized and provides greater biomechanical stability. The maturation process continues, and after about 1.5 years, the bone-implant interface becomes stable and capable of supporting functional loads. This transition is essential for the long-term success of dental implants. The final stage of osseointegration is long-term clinical maintenance and functional stability under load. Over 10 years, the implant remains integrated with the bone, provided that adverse stimuli and overload are avoided. Regular follow-up and proper oral hygiene are essential to preserve the integrity of the bone-implant interface and ensure the longevity of the implant.